Hello, long time no see, but great to be back. I'm gonna attempt to cover basics of autonomic nervous system as well as cholinergic system from a pharmacology point of view. So let's start from ultra basics. Nervous system comprises of central and peripheral. Central has brain and spinal cord. Peripheral nervous system has your somatic nerves, which is soma means body, right? So that has all your sensory nerves, motor nerves, etc. And autonomic. As the word suggests, autonomic means self-regulated or self-governed. This has sympathetic, parasympathetic and enteric. You are no longer in school, please don't forget enteric nervous system. That comprises of your nerve plexuses of the gastrointestinal tract. Sympathetic is your fight, flight, freeze. That is your body's response to any stressful conditions. Whereas parasympathetic is the opposite counterpart, commonly referred to with rest and digest. Sympathetic, in the context of pharmacology, is called the adrenergic nervous system. That's because the post-ganglionic neurotransmitter is adrenaline and noradrenaline. Now we'll understand what that means, but for now, sympathetic is noradrenaline and adrenaline, whereas parasympathetic, the neurotransmitter mainly involved is acetylcholine. Let's quickly see what this postganglionic is. Now, what is ganglion? It is nothing but a collection of cell bodies of nerves outside the central nervous system. So, any cell body in the PNS, all of this is a ganglion. So you have a nerve coming from the spinal cord, it is relaying in the ganglion and then it goes to the effector organ, which means anything before this becomes pre-ganglionic, anything after this becomes post-ganglionic. Simple enough. Now the only thing we need to understand here, all the pre-ganglionic neurotransmitter, all of it is acetylcholine. Whereas post-ganglionic, only parasympathetic is acetylcholine, sympathetic will be adrenaline, noradrenaline, with a few exceptions which we don't have to worry about. Now what did I say? The post-ganglionic neurotransmitter in sympathetic nervous system is adrenaline, noradrenaline, which is why it's called adrenergic system. Whereas in parasympathetic, it is acetylcholine, which is why it's called cholinergic system. So, let's see everything we need to know about the parasympathetic system or cholinergic drugs. We start off with the receptors. Know the receptors like the back of your hand and all the drugs and actions will become super easy. This is a mistake people commonly make. If you're not thorough with the receptors, if you're still confused with the receptors, there's no way you can remember all the drugs. Cholinergic nervous system has two types of receptors, muscarinic and nicotinic, abbreviated as M and N. Under muscarinic, we have M1, M2 and M3. Under nicotinic, we have NM and NN. So what are these receptors doing? M1 is present in autonomic ganglia, gastric glands, enteric neurons and CNS. The main function we need to remember here is it causes histamine release and acid secretion, gastric acid secretion. It also increases intestinal secretion. This is something we already know. If you remember the physiology of gastric acid secretion, there was vagal stimulus to the stomach which caused acid secretion. Right? That's what we're saying here. Remember here the neurotransmitter is acetylcholine, like I've always been telling. On the CNS, it causes learning, memory, motor activity. Remember these functions because each of these functions has a drug you can correlate with. M2 is mostly to do with the heart. Whether it is SA node, AV node, atrium, ventricle, it has a depressant effect on the heart. So it reduces contractility, it slows down the heart, it reduces rhythm. Also a few CNS and visceral functions. It causes contraction of visceral smooth muscles. Now coming to M3, visceral and bronchial smooth muscle contraction, very, very important. What happens if your bronchus is contracting? You can't breathe properly. So bronchial contraction or bronchial smooth muscle is caused by acetylcholine on M3. Remember, these are the receptors. You understand receptor, right? It's a protein which binds to a certain molecule and brings about a certain response. So M3 binds to acetylcholine and causes bronchoconstriction. Iris and ciliary muscle causes constriction of pupil, which we call miosis or meiosis. What is the opposite of this? Mydriasis, which is dilation of pupil. So meiosis and mydriasis, acetylcholine or the parasympathetic nervous system causes constriction of pupil. Exocrine gland secretion, that is every single gland with a duct, be it your salivary glands, exocrine part of pancreas, etc. Vascular endothelium, it causes vasodilation. So go over these once again. M1 is gastric secretion and the CNS functions, M2 is on the heart, and M3 is bronchoconstriction, meiosis and vasodilation. Coming to the nicotinic receptors, on the neuromuscular junction, it causes depolarization and contraction of skeletal muscle. Please note, this is skeletal muscle, your voluntary muscle, not smooth muscle. Every single voluntary muscle that you contract, it happens because of acetylcholine. If you remember EC coupling, this is the E part of it, that is excitation. And N sub N, there are some vague functions like autonomic ganglia, adrenal medulla and CNS. But this is the basic what you need to know about the receptors. Now let's move on to the drugs. First we have cholinergic agonists, also known as parasympathetomimetic drugs. So let's break that down. Cholinergic agonist means it comprises of acetylcholine itself and other drugs that simulate the action of acetylcholine. Or in other words, they favor or they have a positive effect on the parasympathetic nervous system. Mimetic is something which simulates or mimics something. So all these drugs are as good as acetylcholine. Clear? Under this we have the choline esters and alkaloids. Choline esters we have acetylcholine, methacholine, carbachol and bethanechol. Under alkaloids you have muscarine, which is there in mushrooms like Amanita phyllioides. Pilocarpine is a meiotic. Now when I say meiotic, what receptor comes to mind? Just now we did, it's M3. So it simulates M3's receptor, which is a parasympathetic receptor. So it all adds up, right? Arecholine doesn't have many therapeutic effects. So these are the cholinergic agonists. There won't be too many questions on these. Carbachol, bethanechol are used for some kinds of back pain. Yeah, that's pretty much enough. Now we have something called anticholinesterase. For this, let's understand the concept. So you have a presynaptic neuron and a postsynaptic neuron, and this is the synapse. In the synapse, considering that this is parasympathetic nervous system, what is released? Acetylcholine is released, ACH. Now we have this evil guy called acetylcholine esterase. What does it do? It breaks down acetylcholine. So if someone breaks down acetylcholine, they prevent the action of acetylcholine. So therefore, acetylcholine esterase becomes anticholinergic. Clear? It is against cholinergic. Now, let's say you have a drug that inhibits acetylcholine esterase. Okay? What does this become? This becomes an anti or anticholinesterase. So, acetylcholinesterase has a negative effect on acetylcholine. Anticholinesterase has a negative effect on acetylcholinesterase. So therefore, minus into minus, it becomes plus. In other words, anticholinesterases are as good as parasympathomimetic, or in other words, cholinergic drugs, which means their action is not very different from this previous class of drug which we just saw. Of course, they're not acting in the same manner, but ultimately, it has a parasympathetic action. Anticholinesterases are divided as reversible and irreversible, and under each we have carbamate, non-carbamate, carbamate, organophosphate. Under carbamates, we have physostigmine, which is also used as a meiotic. How can this be used as meiotic? Remember, this whole class of drug is pro-acetylcholine. And meiosis is by M3 receptors. So it keeps going back to the same receptor concept. Neostigmine has a variety of uses. Let's just see them one by one. One, it's used in myasthenia gravis. Two, it is used in belladonna poisoning. Now you'll be like, what is belladonna? It is basically atropine. What is atropine? We'll come to that in a bit. It is used in cobra bites. Neostigmine is also used in tricyclic antidepressant poisoning, first generation antihistamine poisoning, stuff like that. It is used in a condition called post-operative paralytic ileus. But neostigmine has a variety of functions commonly asked, okay? Pyridostigmine is much like neostigmine. Now, rivastigmine from carbamates, donepezil and galantamine from non-carbamates, these three guys are used in Alzheimer's. Wait, what? How did Alzheimer's come here? Remember? Learning, memory, motor activity, this is where that is getting applied. Understood? Edrophonium, it is used in the diagnosis of myasthenia gravis. So, without going into too much detail, I'll tell you myasthenia gravis has three types of test. One is ameliorative test, one is provocative test, and one is just checking for the antibody. This ameliorative test is by edrophonium. So if they ask which anticholinesterase is used in diagnosing myasthenia gravis, that would be edrophonium. Which anticholinesterase is used to treat myasthenia gravis, that would be neostigmine. Okay? Tacrine, donepezil, galantamine. Tacrine is like, I don't think it's used much now. These two are used in Alzheimer's. Now we go to irreversible. Under irreversible, you have carbamates, carbaryl and propoxil. Under organophosphate, you have diflose, ecothiopate, malathion, tabunsarinsoman are friends. These names are very weird to remember, but please write it down a couple of times. Say it to yourself. This will help for life. Done? Let's wrap it up with the anticholinergic drugs. They're also called muscarinic antagonists because anticholinergic, which means we saw the cholinergic drugs like acetylcholine, right, which would go and bind to the receptors. These would inhibit the receptors, okay? They are antagonists to the acetylcholine receptors. Specifically, not the nicotinic ones, but the muscarinic ones. So, M1, M2, and M3 blockers is what we're learning. And the king of this class is atropine. So, they're also called atropinic drugs or parasympatholitics. Now, what was parasympathomimetics? It was all these guys. These guys are also parasympathomimetic. Cholinergic agonists are also parasympathomimetic. But these are cholinergic antagonists. Let's quickly see all of these drugs and their uses. First, we learn the classification. Natural, semi-synthetic and synthetic. Under synthetic, we have antisecretory, antispasmodic, mydriatics, vesicoselective drugs and anti-Parkinsonian drugs. The natural anticholinergics are atropine and hyoscine. Atropine, let's just look at the key points. It is used to treat bradycardia and heart blocks. Okay, if there is heart block, there will be bradycardia. So this is all by antagonizing M2. So I've written all the receptors as well. Please note, these are not agonists, they are antagonists to these receptors. Atropine is the drug of choice for OP or organophosphate poisoning. Because look at this. Where are the OP compounds? They are here, right? They are the irreversible anticholinesterases. So this is pro-acetylcholine, OP. And atropine is anti-acetylcholine, okay? So if you have OP poisoning, atropine can go and tackle that. This is a very important use. Also mushroom or muscarine poisoning. Then atropine has a use in pulmonary edema as well. It is used as a mydriatic and cycloplegic infrequently. Once again, what was meiosis? It is pupillary constriction. Mydriasis is pupillary dilation. Okay. What is cycloplegic? It is a drug which causes paralysis of accommodation. You know accommodation, right? The changes in the lens when an object is moving from far to near or when you have to shift your focus. So, paralysis of accommodation. Okay, this is important. Now, atropine itself acts as a mydriatic and cycloplegic for which it blocks M3 receptor. Atropine itself has these uses. Coming to hyoscine, It is used in motion sickness. It is used in narco-analysis. Narco-analysis is nothing but, this is also called truth serum drugs. Sorry about the flickering. I don't know why that's happening. Truth serum drugs means it's based on the concept that if somebody is, just about to lose consciousness, the truth will leap out and they'll not be oriented enough to lie. So people give hyoscine and then they ask them questions to, knock the truth out of them. So that is narco-analysis. It is also used as an analgesic. Like you find these scopolamine patches that people use for pain relief. These are the natural ones. Under semi-synthetic, you have atropine methonitrate, which is very similar to atropine. Homatropine. So homatropine is used in the eye, right? You have eye drops of homatropine, which will cause mydriasis or pupillary dilation. Hyoscine butyl bromide. Let's see uska uses. It's used in gastric and esophageal spasm. Then we have our friends ipratropium bromide and tiotropium bromide. So these act on M3. Remember, M3 was causing bronchoconstriction. So M3 blockers will cause bronchodilation. It has gradual onset and a late peak. So it's used as a prophylactic in COPD rather than for rapid relief, which means if someone's having an acute attack of COPD, they're not able to breathe. That's not why we use these. But if there is a chronic COPD patient, on a daily basis, they'll be taking ipratropium, tiotropium bromide. Okay? It acts on the large central airways, which is why it's preferred in COPD rather than asthma. What drug do we use in asthma? That we'll see in adrenergic. Okay? But for now, in the parasympatholytic or the atropinic drugs, ipratropium bromide and tiotropium bromide are used. And tiotropium is supposed to be more long-lasting. Okay, natural, semi-synthetic done. Now we come to the synthetic compounds in the same class. We have the anti-secretory antispasmodics, which are further divided into quaternary compounds and tertiary compounds. What do we need to know about the quaternary compounds? They have poor oral absorption, poor CNS penetration, and slower elimination because they are all polar. So in this we have propanthelene, oxyphenonium, clidinium, simetropium bromide, isopropamide, and glycopyrrolate. The names can be a mouthful, but the more you say them, the more you'll remember. Propanthelene, oxyphenonium, clidinium, all of this is used for peptic ulcer. They reduce gastric acid secretion by inhibiting M1 receptors, which we saw. Clidinium, simetropium bromide, and isopropamide are used for irritable bowel syndrome, that is GI hypermotility. Remember, this is all treatment, this is not side effect. Okay, glycopyrrolate is a pre-anesthetic medication. So there is a separate question of pre-anesthetic medication, but basically what you need to know is these reduce all sorts of secretions. We don't want a lot of bronchial and GI and intestinal secretions when someone's under anesthesia because it increases the risk of aspiration. So you give glycopyrrolate as a pre-anesthetic medication, and this action is by inhibition of M1, M3. Okay, quaternary compounds done. The tertiary amines are dicyclomine, valithamate, pyrenzepine. Dicyclomine is mostly M1 antagonism. It's a smooth muscle relaxant, antiemetic. It is used to treat dysmenorrhea and IBS. Valithamate causes cervical dilatation, so it's used to hasten labor. It's also used in renal colic, abdominal colic. Pyrenzepine is just like dicyclomine, but it doesn't have too many atropinic side effects. So if you give any drug in this class, the person will have dry mouth and all secretions will go down. Pyrenzepine is very specific, so it can be used for peptic ulcer. So anti-secretory and antispasmodics are all done. Coming to the mydriatics, we have cyclopentalate and tropicamide. These are commonly used mydriatics. They also cause cycloplegia. What is cycloplegia? Loss of accommodation or paralysis of accommodation. So not only are they dilating the pupil, they are also fixing, so that the eye is not undergoing any accommodation. Coming to the vesico-selective drug. Vesico, it refers to urinary bladder, right? Bladder. So these are all the drugs in this class which are specific to bladder. Oxybutynin, flavoxate, tolterodine, darifenacin, solifenacin. I can almost hear these in Dr. Ravi Shankar's voice as I say it. This is all used in detrusor instability, resulting in increased frequency and incontinence. So, what are the specific conditions where we use these drugs? Post prostatectomy vesicle spasm. Again, vesicle refers to bladder. Neurogenic bladder, spina bifida, and nocturnal enuresis. Anti-Parkinsonian drugs, you have trihexyphenidyl, procyclidine, and biperidine. Okay, again the names are a mouthful. Anti-Parkinsonian drugs, there is a whole chapter on this. There's also another video I've made on this. But for now, remember, in drug-induced Parkinsonism. So there are certain drugs which can cause Parkinsonism. In that case, only these will help. You can't use your L-Dopa, you can't use anything else. You have to turn to atropinic anti-Parkinsonian drugs. These are also known as centrally acting anti-Parkinsonian anticholinergic drugs. I hope I did justice. If enough of you like this video and want the same for Adrenergic, I'll be more than happy to do that. Please subscribe if you haven't already. Refer this to your friends. I don't really want to grow my channel per se. I just want people to learn. Thank you.